pulmonary, and chronic kidney disease. Just a reminder that this is one of our special populations lectures, and special populations is just ACSM's terms for anybody who may need modifications or special considerations to their general exercise recommendations. It's a tiny brief overview. I teach a semester-long course on this topic, and I still have to select which material to leave out. So for this class, we're going to focus on the ones that there's a lot of evidence for the benefit of exercise and the specifics of the exercise training program, and also ones that are most commonly encountered. For anyone with a chronic condition, exercise training, we need to examine that the benefits outweigh the risks. We need to do careful screening on the person. We want to learn the pathophysiology and medication effects as applicable. We want to be aware of any exercise contraindications. That means any reason why the person may not exercise for safety reasons, not because they don't want to, because there's something that may tell us that they need to not exercise that day. There can be relative contraindications, which are usually kind of short term, and then absolute contraindications, which could be longer or require medical intervention before being cleared to exercise again. We also want to think about the person's barrier to exercise. Everyone has a barrier, but a lot of times our special populations group has additional barriers. For example, older adults may have additional constraints with driving or with finances. Some people with chronic diseases will have additional appointments that are already competing with their gym time and so forth. So it's our job to help the person figure out what their barriers are and what some strategies are to mitigate those barriers so that they can exercise. And we always want to make our exercise training plan individualized and specific, but it's especially important for our special populations. I mentioned that we want the benefits of the exercise to outweigh the risks, and this just means that the person gets enough benefit from the exercise that it's worth the risk. The risk is low or moderate in comparison to the exercise benefits being higher. Some specific exercise benefits for our special populations include improved cardiorespiratory fitness, flexibility, balance, and skeletal muscle strength. That's the same with anyone, but it may be especially important if we're working with a special population that, for example, is deconditioned. Improvements in quality of life, reduction in symptoms and side effects, improvements in breathing, and also a maintenance or slowing the rate of muscle mass. This is a big concern. A lot of times with our special populations, there may be an increased risk of loss of skeletal muscle mass and function. We may not be able to get them to gain skeletal muscle mass, but if we could at least slow the rate of loss, that's a huge benefit. For our FIT VP for special populations, before we figure this out, there are a few items we need to consider. First, we want to look up their medical history, including all medications. We want to look up the physiology of the medical condition if we're not familiar with it. We want to look up their medications that they listed and their impact on physiology. For exercise, we're especially looking for ones that have effects, either directly or as a side effect, on heart rate, blood pressure, skeletal muscle, lungs, balance, vertigo, anything you can think that may be impacted by exercise, that we don't give them a double hit with their medication. So for example, if their heart rate is limited by medications they're taking, we can't use heart rate for an exercise training prescription. If they're taking 3 medications that may cause vertigo, they're at an increased risk of vertigo, and we want to be aware of that if we're prescribing any exercise that may be challenging to their balance. And again, we want to figure out what their barriers to exercise are, what their contraindications are, make sure they're aware of when they should stop exercising, and also help them plan for working around their barriers to hopefully get them to be a successful exerciser. Once we have all of this, then we can make our exercise training plan. We are going to do one that starts low and slow. And what this means is that we're going to start at a lower intensity and do a slower progression than we may do with somebody who was healthy and didn't have a chronic condition. Depending on the conditioning of the individual, we may start with 10-minute bouts and work up to ACSM recommendations. It may be even lower that you have to start with. You may have to start with 5 minutes or 3 minutes. Interval training is really great for people that are deconditioned because you can give them small amounts of exercise to do and that they feel success that they completed their 10 2-minute bouts or whatever it is you prescribe for them, instead of like, oh no, I couldn't do 20 minutes, I had to stop after 10. If they're doing some intervals, even if it's low intensity, if you have these breaks worked in, that it's a confidence boost to them. It makes them feel like they can do the exercise. And then we like hitting goals, right? That always feels good to hit a goal, complete our exercise session. We also want to remind them that some exercise is always better than none. And we are also working to reduce sedentary time. So it's not just about exercising and doing physical activity, but also reducing the amount of time that we are sitting or laying down. The first special population of this lecture is heart disease. This includes several conditions, most commonly atherosclerosis, myocardial ischemia, which is the term for a loss of blood flow and nutrients to part of the heart muscle, and myocardial infarction, which is a technical term for a heart attack. Two other super common heart diseases are hypertension and peripheral artery disease, especially hypertension. Okay, so first up, coronary artery disease, which includes atherosclerosis, is one of the most prevalent types of cardiovascular disease and accounts for the most cardiovascular deaths. As I mentioned, this includes atherosclerosis, which is when fatty streaks develop, causing the artery walls to thicken. This reduces the lumen diameter. So if you remember anatomy, the inside of your artery is referred to as the lumen. And we like wide open lumens where the blood can freely flow and where the artery muscles are not stiff, where they can flex with each contraction of the heart. So with the fatty streaks develop, it causes the artery wall to thicken. This impedes blood flow, and it usually can involve a stiffening of the arterial wall as well, so we're not getting as much. So we're getting this increased pressure from a smaller lumen, and then there may be some loss in the flexibility of the wall as well. And atherosclerosis involves a cycle of repair and remodeling. This is from your textbook, and we have 4 pictures here. You can think of this as kind of like a progression of atherosclerosis, starting with the top left. This is a normal coronary artery. There's no fat, no yellow part in it. The lumen is open. There's nothing impeding it. We then have a fatty streak develop. And in this, the lumen is usually about the same diameter still. It's not really affected, but these fatty streaks are starting to build up in the artery wall, which is not great. It can then become a fibrous plaque. Lots of stuff goes in there. I have some slides. We're going to talk about that next. But immune cells, more fat, lots of inflammation. And so the artery wall, as you can see, is really starting to thicken and the lumen is narrowing. And this can progress to even more of a narrowing and become what's called a complicated plaque. This is from a research article, and it shows the same thing as the previous, or very similar things as the previous picture, but it gives you a little more detail as far as what is actually in that those fatty streaks. So it starts off with there's immune cell infiltrations. For example, monocytes go into the cell wall there. They become what's known as a macrophage. So monocyte is what they're called when they are going through circulation. And then once it takes up residence in a cell, it is transformed into a macrophage, and they're a pretty big immune cell. These macrophages want to get rid of anything they deem as being foreign, like that shouldn't be there. So that fat should not be in the arterial wall. So the macrophage is like, I'm going to eat it up. I'm going to get rid of it, and it's not going to be there anymore. But the problem is that macrophage is usually still there as well. And as it's eating up this fat, trying to get rid of it, it's producing a lot of pro-inflammatory cytokines. A lot of inflammation is occurring in the cell wall, which just continues to make this worse of a problem. It recruits other immune cells, which again continues to increase inflammation. We have just a lot of things accumulating that should not be in there. As it progresses, we can have thrombosis, which is where part of this leaks out, and it can either cause a clot right there, or it can break off, float somewhere else, and cause a clot in a more narrow artery. So that's not good. Or we can continue to have it develop and make the lumen even more narrow. There are two development models. The first one I'm going to show you is the traditional one, and this one is from the research article that is posted in your lecture topic reading. So as a reminder, for those, you only have to know what I present in class. If you want to read more about it, if you want to look at this figure in depth, then you can refer back to that research article. But unless it was an assigned reading that you had a Blackboard quiz on, you're only responsible for knowing what I present in class. So traditionally, like I mentioned, we have these monocytes, immune cells, which are, we want monocytes. They are an important part of our innate immune system. They are flowing around, let's say, no, let's not say floating, let's say flowing around through our blood. And they may be attracted to the arterial cell wall, maybe because this, again, this fatty streak has started, and they're going to roll along. They're going to find a space between the cells that they can squeeze into and go into that area beneath the inside of the arteries, between the inner wall and the outer wall. And this is where they're going to start eating things up. They're going to produce inflammation, and they accumulate cholesterol in there. They can become necrotic. They only live for so long, and then when they die, they can release some of the stuff they've eaten up. So it's not a good situation. So this one here is what we're most familiar with, because it involves cholesterol, especially like high cholesterol, for this model to develop. Another model, though, does not involve cholesterol, but it still involves the immune system. It's just a different activation that signals the immune cells to squeeze between these the cells in the cell wall to go into between that inner and outer layer of your artery. And in this particular model, somebody can have normal cholesterol and still develop atherosclerosis through this model. And the immune cells find some other signal that triggers them. I'm being very vague. We know what the other signal is, but you don't have to know it. What I want you to know is that the immune cell, the monocyte, finds a signal, and that tells it to go into the, to squeeze through the cells, the endothelial. So in the first model, there was some cholesterol that had been oxidized, but there's cholesterol that it was damaged that signaled it. In this one, the cholesterol is fine. It's another signal that tells it to go in there. And then the rest of it is the same. It's going to eat up things. It's going to produce inflammation. It's going to become necrotic and release its stuff when it's done. Continuing with heart disease, the next thing I want to talk about is C-reactive protein, which is abbreviated CRP. And this is pretty important in understanding cardiovascular disease risk and also exercise. This is a marker, another marker we can use for cardiovascular disease risk. It is a plasma protein that indicates inflammation, so it's circulating through our bloodstream. So that means with plasma protein, it's produced somewhere and then it's circulating through our bloodstream. The levels rise in response to inflammation resulting from coronary artery disease, cancer, infection, or trauma, and then also unknown sources. Those are the ones that we know, that we're most aware of, but there can be other sources that lead to an increase in CRP production and release as well. What is interesting is that CRP levels can independently predict risk for heart attack. So independent of LDL or other cardiovascular disease risk factors, CRP is associated with an increased risk for myocardial infarctions. We even have a little table for it. If somebody has CRP below 1 milligram per liter, they're considered low risk. Between 1 to 3, average risk. So not increased, but also not a low risk. And then greater than 3, they are considered to be at a high risk of cardiovascular disease. In this particular study, they looked at both LDL cholesterol, remember that's our bad cholesterol, and CRP. And the people with the lowest risk had both low LDL and low CRP. The people with the highest risk for cardiovascular disease had both high LDL, or excuse me, elevated LDL and high CRP. And then if somebody only had high CRP or only had high LDL, they were at an equal risk for cardiovascular disease. A C-reactive protein can respond to several things. One, it can respond to medications. So in this table here, these are 2 types of statins. Statins is a class of medication that reduces cholesterol. And with these people, they measure their CRP, they're randomized to one of these 2 types of cholesterol-lowering medications, and their blood was drawn after 30 days, 4 months, and then at the end of the study. And in both groups, this is a really large sample size, by the way, so we know this is a pretty strong relationship. So in both groups, their CRP was lower after at least 30 days of these cholesterol-lowering medications. So the thought is that not only are people who take these medications getting a benefit from having their cholesterol lower, but also that the reduction in CRP may further decrease their risk of cardiovascular disease. And these medications do have a lot of risks associated with them, so we don't want to just put everybody on it just because it reduces their risk of cardiovascular disease and of MIs. There should be, they should be at an elevated risk where they would have more benefits from taking this than from not. CRP does respond to physical activity and exercise. This is a study of mine, and we had a group of participants who were either physically active or physically inactive. And the physically active participants had significantly lower CRP. You can see that if we look at the cardiovascular event risk from the other slide, then our physically active participants were about in the low or average risk, but our physically inactive participants on average were at the high or elevated risk for cardiovascular disease based on their CRP. The group that was physically inactive, we then exercise trained them for 12 weeks. It was only resistance training. There was no cardiovascular or cardiorespiratory exercises. They walked on a treadmill for a warm-up for 5 minutes before starting their resistance training exercises, but we weren't specifically doing cardiorespiratory exercise training. And they still reduced their CRP. So even with not targeting cardiorespiratory type exercises, there was still this benefit to them. Hypertension. Symptoms with hypertension often go unnoticed. It's considered a persistent elevation, either systolic, that's the top number, or diastolic blood pressure. Primary hypertension accounts for about 90-95% of all cases. There's no established pathology. People just get high blood pressure. They don't have a known reason for it. There's secondary hypertension where we do know the reason for it. So it might be that they have renal disease, stress, it might be a side effect of medication they're taking in other ways. But most people that have high blood pressure, there's no known reason behind why they have high blood pressure. It just tends to happen as we get older. Myocardial ischemia, that is the word for a heart attack, the technical term for that. And it's basically ischemia. Sorry, ischemia is not heart attack. I was thinking MI because that's the same abbreviation, but it's not. Ischemia is a lack of oxygen to part of the heart muscle. And so we can have, technically, again, it's an imbalance between myocardial oxygen demand and supply. Stable means that it results from increased demand from the heart. So for example, if somebody does not have chest pain at rest, but they have chest pain every time they walk faster than a certain pace or climb more than so many stairs, that's considered stable angina. It only happens when there's an increased demand on the heart. Unstable is more severe, is a little bit less predictable, and is usually observed in a resting state as well as an increased demand state. Along with this, the person often has angina, which is chest pain. That's how that they can figure out that somebody may be having myocardial ischemia, is that they're complaining of chest pain. And in the early stage, it tends to get better when exercise stops or intensity decreases. Peripheral artery disease. This is an occlusion of vessels of the upper and lower limbs as a result of atherosclerosis. The resulting ischemia, lack of oxygen to the working muscle, can cause pain and easy fatigability. The most common symptom is intermittent claudication, a cramping, aching sensation affecting calf muscles, especially during weight-bearing exercise. A lot of times with this, what you'll see is the person will start walking on the treadmill, and then at about the same time, every exercise session is when the pain will onset. So they're fine for the first 10 minutes or even longer, 20 minutes. And then once they hit the 18, 20 minute mark, that's when the calf pain starts. Or they're fine walking at a slow warm-up pace, but soon after the pace is increased and the demand is higher, the demand on the working skeletal muscle is higher, then that's when the ischemia starts. It's generally safe for people who have ischemia to exercise as long as we take precautions with it. It's not ischemia. Peripheral artery disease, even if they have pain in the muscles. That's what I was trying to say. Cardiac ischemia, that we want to get checked out. The people usually know they have this, and they'll come to you with a recommendation for exercise. It's graded on a 4-point scale where 0 is asymptomatic and 4 is loss of tissue in the limbs because of the loss of oxygen and blood supply. And this severity is based on the ankle brachial index, ABI. We can assess it in exercise physiologists who are trained to assess this, but usually we have people come to us with this that was assessed by their clinician. People with cardiovascular disease are often taking medications for it. One of the common ones that I want to talk about because it greatly impacts how we do our exercise prescription is a class of medications called beta blockers. We need to use caution with exercise because this limits the heart rate rise. Now that means a person can still do a moderate intensity exercise, but we can't use heart rate to judge where they are in this. You don't have to memorize this. I just like little figures because I think you figured out by now. This is one I found online in a nursing website. And beta blockers usually end in OLOL. So if you look at someone's medical history and you see something that ends in OLOL, like propranolol, then you'd want to look that up to make sure it's, if you suspect it's beta blocker, look it up to find out what class medication it is. It blocks beta receptors in the heart, which cause a decreased heart rate, decreased force of contraction, and a decreased rate of AV conduction. Now, if somebody has high blood pressure, we want to help them lower blood pressure. These are things that we have happen with this. As we exercise, we do have an increase a lot of times in our beta androgenic hormones, which this receptor would block. And so even though the person is exercising and reaching a higher working capacity, a higher intensity of activity, their heart rate has a modest increase. Doesn't reflect what their intensity of exercise really is. So if we have somebody on a beta blocker, instead we're going to use RPE scale to prescribe their exercise. And we have a table in ACSM you can refer to in your textbook that tells you which RPE corresponds to which intensity of exercise. It's also in the prescription, the exercise prescription lecture that I have. I put that table in there for you. With cardiovascular disease, there are 3 pain scales we can use. We can use the angina scale, so chest pain. We use claudication scale, so people that have the intermittent claudication in their legs. And there's also a dyspnea scale, so difficulty breathing scale. So these are other ways that we can use our exercise prescription. So we might go and say with the Borg scale, we want you to work in between 11 and 13, but let's say they have PAD, but on your claudication scale, I wanted to keep it at a 2 where it's a moderate discomfort, pain, but you can be diverted by it. You can be distracted by it. There are lots of benefits for exercise for people with cardiovascular disease. And many of these are the same as somebody who doesn't have cardiovascular disease. Increased maximal oxygen uptake, improved heart functioning and reduced angina, improved health of blood vessels, blood lipid profile, improved recovery from an MI, improved mood and reduced anxiety, and improved insulin sensitivity, and of course, reduced risk of death. Moving on to metabolic diseases, this includes diabetes, hyperlipidemia, obesity, metabolic syndrome, and COPD, chronic obstructive pulmonary disease. The role of exercise in metabolic diseases. Exercise can help improve insulin sensitivity, which leads to greater control of blood glucose levels. It can help reduce the amount of medication required. Lower doses tend to have lower side effects, so this is nice. Lower blood concentrations of LDL and increased concentrations of HDL. My little note here where I'm saying, well, and what I'm saying is that exercise will modestly decrease LDL in most people if they're not changing their weight, if they're weight stable and they're exercising. It's probably going to be a modest decrease in LDL. It's usually not enough for somebody who's on cholesterol lower medication to reduce their LDL enough to get off the medication. But it's still helpful. Maybe they can lower their dose, but it's usually they don't get taken off it. If the person also reduces their body weight and maybe changes their dietary habits, so a comprehensive lifestyle change, maybe they stop smoking as well, they may get off some of the medications, but just by exercise alone is difficult. However, exercise, even though it's not great at lowering LDL, is really good at increasing HDL. So that one we do have a good evidence that it can be clinically relevant. The LDL, maybe it reduces somebody's 20 points, so they went from 380 to 360. They're still going to need to be medicated, but we could maybe move their HDL from being in the risk below 40 up above that. The role of exercise in treating obesity is most effective when used in combination with caloric restriction. And exercise yields improvement in the complex of risk factors associated with metabolic syndrome. One slide summary of insulin. Actually, it's 2 slides, but the little figure here, we'll say one figure summary of insulin. So with insulin, it binds to insulin receptors. Lots of our tissue has insulin receptors. A lot of our tissue needs glucose, right? So the insulin binds to the insulin receptor. It signals this GLUT4 containing vessel to go to the surface of the cell, and then glucose can happily make its way inside the cell, and the cell's happy because it has some glucose. So exercise improves insulin sensitivity, so it improves this binding of insulin to the insulin receptor. And it also can cause mechanical contractions that will help the cells manually bring in glucose. We get 2 benefits from the exercise. We get the improved sensitivity, and then we also get the actual mechanical uptake of glucose as well. Insulin's super important for us. It helps with glucose regulation, with storage and uptake, including glycogen synthesis, protein synthesis, fatty acid synthesis, mitogenic response, that's a fancy term for growth, sodium transport, lipolysis, gluconeogenesis, apoptosis. So it's not just about regulating blood glucose. That's what you're supposed to get from this. Insulin is involved with a lot of processes in our bodies. So improving the sensitivity of it doesn't just improve our blood glucose, it improves a lot of things in our body, which could be one potential reason for why exercise is so beneficial. Talking about diabetes, we have type 1 and type 2 diabetes. Type 1 is an autoimmune disorder in which immune cells attack beta cells in the pancreas. This means that the cells are no longer able to produce insulin. No insulin, that's I shouldn't say that. They produce very little insulin. Usually, I think usually just a little bit, but it really reduces the ability to produce insulin. If there's no insulin, then not as much glucose is being uptaken because we're not getting those GLUT4 vessels in the cell surface. So it results in elevated blood glucose levels. Symptoms include hunger, severe systematic weakness, and weight loss. Systemic weakness, not systematic. Sorry, I guess it sort of systematically does the system. But. Type 2 diabetes, this is more common than type 1. The pancreas continues to produce insulin, but the insulin receptors on target cells are unresponsive. So when we talk about exercise improving insulin sensitivity, it's improving these insulin receptors on the target cells. They're becoming less unresponsive, becoming more responsive. And because of the reduced sensitivity, the cell is still saying, hey, I'm not getting glucose. Even though there's plenty out there, the cell's like, I'm not getting any. So then there's even more glucose that the body produces to try and meet those needs. And it's just not good, as you can imagine. Diabetes-related complications include a lot of cardiovascular disease, including high blood pressure, heart disease, stroke, also includes liver damage, retinopathy. So that would be disease of the retinopathy, sorry, of the retina, the eyes. Neuropathy, poor circulation. So both the kidneys and the nervous system are affected by this as well. Continuing with precautions during exercise for people with diabetes. People with diabetes have an increased risk for cardiovascular disease, hypoglycemia, that's low blood sugar, dehydration. There's also high risk, increased risk associated with high intensity resistance training, and an increased risk of injury to the extremities. However, there are a lot of benefits to exercise, and these outweigh the risks for most people. There's improved insulin sensitivity and glucose tolerance, reduced risk of cardiovascular disease, reduced need for medication a lot of times, improved mood and well-being, and better weight management. Other special considerations: hypoglycemia can occur both during and after exercise. Hyperglycemia can occur in type 1 diabetics with poor blood glucose control. If I say that correctly, hypoglycemia occurs during and after exercise, so low blood sugar, right? Because the exercise is going to help draw it in to the cells. And then hyperglycemia, high blood sugar, can occur if there's poor blood glucose control. Those with neuropathy of the hands and feet may have gait or balance issues, avoid quick changes. These are usually people that have poorly controlled blood glucose. They're not taking their medications, they can't afford it, they just don't take it for whatever reason. They're at increased risk for this. This is not a current ACSM recommendation, but we used to recommend that people with diabetes participate in physical activity at the approximate same time each day. So if they usually do it in the afternoon, after lunch, or before their afternoon snack, they usually before dinner, whatever it is, that because exercise is kind of like a medication in the sense that it improves glucose uptake, that improves insulin sensitivity, it's ideal that somebody who has diabetes knows when they're going to get that glucose lowering effect. It's the safest thing for them. So that's the recommendation we usually do. ACSM doesn't currently make that recommendation. I suspect it's because we know that any exercise is still better than no exercise. We don't want somebody to be like, oh gosh, I can't do my exercise when I usually do it, so I'm just going to skip it today. We know it'd be better for them to do it at some other time. So that's probably why we don't really recommend that anymore, but ideally they would do it at the same time every day. New organ system. Let's talk about the lungs. We have COPD, chronic obstructive pulmonary diseases, and CRPD, chronic restrictive pulmonary diseases. So COPDs is an umbrella term used for a collection of pulmonary diseases, including chronic bronchitis, emphysema, and asthma, whereas the chronic restrictive pulmonary diseases are disorders that are characterized by a reduction in lung volume. Most notably, muscular dystrophy, and possibly obesity as well. There are several different conditions that can affect the lungs. One thing where they have in common is their risk and likelihood for COPD. So emphysema, chronic bronchitis, chronic asthma, asthmatic bronchitis. Okay, let's start with asthma. ACSM's aerobic training guidelines for those with controlled asthma include performing cardiorespiratory type exercises 3 to 5 days per week for 20 to 60 minutes of continuous or intermittent activity. So it's pretty close to the recommendations. In fact, it's 3 minutes, 3 days if it's vigorous, 5 days if it's moderate. The optimal training intensity is not known, so we just recommend that they follow the guidelines for older adults. Young people can follow the guidelines for young people. They have to follow the older adult ones. If somebody has moderate to severe COPD, still perform the exercises 3 to 5 days a week, just realize that the initial duration may only be a few minutes and slowly increase as the client's health improves. Ideally, the intensity should be 40 to 60% of peak work rate or base intensity on dyspnea ratings. If we don't know their work rate, that's usually not something we test. I just said that they would come to us. Then we can use the dyspnea ratings instead. So that was on the scale that I gave you earlier with the cardiovascular disease, what's on the bottom. And we generally regard walking or stationary cycling as safe for people with COPD. For resistance training, they can follow the same guidelines as a general population. If it's moderate to severe, then COPD, then they should follow the guidelines for seniors. People with moderate to severe COPD often have additional pulmonary therapy that they're doing where they're training the inspiratory muscles. Special considerations, we want to include a longer warm-up before cardiorespiratory exercise and progress more slowly, and also perform a longer cool down. The mode is important. EIA stands for exercise-induced asthma, and it's more likely after certain forms of exercise. It may be more likely the person exercises outdoors versus indoors, or outdoors during certain seasons. It may need a longer warm-up and cool down than somebody with mild COPD or with somebody who does not have a chronic disease. And on the dyspnea scale from of 1 to 10, the one I showed you only went up to 4. So there's another scale you can use that gives a little more range to work with that goes from 0 to 10. We're aiming for a value in 4 to 6 on that. Chronic kidney disease. Chronic kidney disease arises from complications with numerous diseases that result in change in the structure and functional ability of the kidneys. The best indicator we have for kidney function is GFR. This is a relatively easy to estimate in people. It's the total amount of fluid filtered through the nephrons per unit of time. So filtered through the kidneys. In people with chronic kidney disease, exercise lowers systolic and diastolic blood pressure. This is people that have high blood pressure. One of the potential causes, if it's secondary, is chronic kidney disease. Right? But exercise can help reduce blood pressure. It can help reduce resting heart rate. Resistance exercise specifically can increase muscular strength in pre-dialysis, dialysis, and transplant populations. So these are people that usually have a lot of protein wasting, which means they lose a lot of skeletal mass, which usually means that they are losing skeletal muscle function as well. Can also attenuate muscle wasting and cachexia. Anybody remember what cachexia means? We talked about it in the exercise oncology lecture. So it's a loss of skeletal muscle mass associated with a chronic disease or disease. And it also has a loss of function and inflammation as part of its development. So it's not atrophy, that's different. You know, you put a cast on and have atrophy. You're not cachectic. Getting to the specifics of cardiovascular disease, FIT. The frequency is 5 or more days per week. Cardiovascular disease clients usually have limited functional capacities, especially as the disease moves from mild on to moderate and severe. 10 to 15 minutes performed 2 or 3 times a day may be more feasible than doing 30 plus minutes all at once. If they're on heart rate modifying medications, remember we need to use RP instead of heart rate. And we always want the exercise to be below the myocardial ischemic threshold, so where it causes chest pain, because that means that they're likely not having a loss of blood flow to the area of the heart because their oxygen demand is being met. HIIT can improve exercise capacity and quality of life. So HIIT exercise may be particularly useful for people with cardiovascular disease. Our overall goal is to progress to 60 minutes of cardiovascular exercise per day. Yes, this is higher than the general ACSM recommendation, but due to the strong relationship between exercise and a reduction in cardiovascular disease risk, if somebody already has cardiovascular disease, we want to improve their mortality, reduce disease progression, perhaps maybe even reverse a little bit of it if we can. We can't get rid of atherosclerosis, for example, but we may be able to help with their blood pressure. For resistance training, the FIT is the same as the general healthy population, do that age matched. Most cardiac patients, though, may start at a lower intensity than the general population. They may be more likely to be deconditioned. Your textbook has these wonderful tables. There's table 8.1 and 8.2 in your book. The first one's for CRE. I really like this. This was very helpful when I was studying to take the ACSM EP exam. And personally, I found it easier to memorize this way instead of memorizing by disease. So we have the frequency for the conditions we just talked about, intensity, time, type, and then we have the same for resistance training. Our FIT for metabolic diseases, we can safely work with clients with well-controlled type 2 diabetes. Frequency is 5 to 7 days per week. Intensity 50 to 80% of heart rate reserve, which is an RP of about 12 to 16. We want to start with an accumulation of 20 minutes and progress to 60 minutes a day. And resistance training guidelines, again, are going to be the same as general population. Special considerations for people with peripheral artery disease. A claudication scale, time, or distance of the onset of symptoms to monitor exercise. Again, when I work with people with PAD, it's usually at a certain duration of exercise or intensity that we see this become a problem. And so if you know the person always has leg pain starting at minute 20, then stop at minute 15, do a stretching break, and then have them do another 15 minutes of exercise. They may benefit from work rest intervals and provide relief from the onset of it. Weight-bearing exercise should be the primary type of exercise. So a lot of times people think okay, well, the claudication, there's this pain in the leg, so let's avoid exercises that are weight-bearing. That's not the best path for somebody with PAD. It's fine to use non-weight bearing exercise for warm and cool down, but their main exercise should be done weight bearing. And elliptical, can be weight bearing. Treadmill is very effective. It's also good to be aware that a cold environment may aggravate symptoms of claudication. Not really a problem for us very often here in Houston, but we should be aware of this. If this is the case, the person will probably require a longer warm-up. So special considerations for people with diabetes. There should be blood glucose monitoring before, during, and after exercise. We want to keep a readily available source of carbohydrates available at all times. In our exercise training facility here, I keep apple juice in a little refrigerator, not just for people that have diabetes, but just because I work with a lot of special populations. And so there can be a lot going on that they just need a little bit of sugar after the workout. If pre or during exercise blood glucose measurements are below 70 milligrams per deciliter, the carbohydrate snack should be administered and recheck the blood glucose after a little bit to allow time to digest. On the other side, though, if pre-exercise blood glucose values are above 250 and ketones are present, or if blood glucose alone is above 300 milligrams per deciliter, then blood glucose definitely needs to be lowered before initiating exercise. Did they forget to take their medication? What's going on? Also, we ideally want to avoid exercise when insulin levels are peaking. If they inject it, if it's because their medication is improving the sensitivity, we want to avoid giving them a double punch of whatever those reasons for the insulin rise is, and then also exercise.